Welcome to week 9. This week is a newly added topic to the annual Implementation Science reading course. By popular demand, we have added a session on dissemination science and practice. And today's didactic portion will be co-led by myself and Nanette Benbow, who is faculty in the Third Coast Center for AIDS Research and also the Department of Psychiatry and Behavioral Sciences. We had a lot of fun putting this content together over the last couple of weeks, and we are really looking forward to this conversation today. Before we begin, we would love it if those of you that are joining could just throw in the chat what the phrase dissemination science means to you. So when you hear us say, we're going to be presenting on dissemination science, what are some words that come to mind as to how you might define this field of science? We'd love it if you could just pop that in the chat before we begin. Awesome. Health communication, spread, promote. Fabulous word so far. Purposeful sharing of information, communication, distribution, awareness. And then Cindy's asking the question that we'll hope to answer today, which what is the difference between the dissemination and implementation? Flow, communication. Fabulous. Okay, thank you all. So I'm delighted to see those terms because this is a bit of an elusive concept for a lot of folks. And when we talk about dissemination, we tend to think about words like diffusion, spread, flow of information, but it isn't always clear how that's different from implementation and how exactly the two work together. So that's one of our objectives for today, is to talk about how we believe dissemination research can complement implementation research. So our agenda for the next 30 minutes or so is, first, we're going to talk about what is implementation science. Then we'll take a bit of time to talk about how we believe that the D complements the I. So how exactly can dissemination and implementation science work together to really advance the uptake of effective treatment? Then we have a really nice case showing dissemination science and practice principles in action that will be led by Nanette. And then we'll close with just some additional resources and announcements before going to our discussion group. This is our last didactic session, so thank you for making it this far with us in the reading course. It's been a really fun journey, and we're really excited about today. We do always like to remind you what our learning objectives are. So for this week, we're hoping to define and communicate some key research terms. We're going to try to define what is and what is not dissemination research. Most importantly, we're going to try to differentiate different dissemination research from other related areas. That was a tongue twister. Differentiate dissemination research. And then we're going to discuss some examples of research and practice. All right, let's jump into the first part of the agenda. You all remember this bridge? I'm looking to see if I see any nods or heads. Yeah, I'm seeing some nods. Okay, so this was week 1. We shared this bridge, which we have since titled, thanks to our friends Hendricks Brown, The Bridge Over Troubled Waters. But this is our D&I bridge, bridging the gap between what we know and what we do. Since we presented this in week 1, it's actually been published. So it's out in Implementation Science Communications with an overview of these key terms. But I want to reorient us to this because dissemination science arguably targets one of these big red bubbles. So we've spent the whole bulk of the course talking about the public health supply gap and trying to increase the supply of effective services in the community. And today, if we put our economics hats on, we're going to be talking about increasing patient demand for services. So how do we actually increase the demand for effective treatment in clinical and community care settings? Just to really make this concrete, we think about the I, or implementation science, as again, increasing supply and bridging the gap between the care that could be available if we used our best medical knowledge versus the care that actually is available in terms of medical and public health practice. This is a slide we showed you in week 1, and I just want to reorient us that this is really what we've been spending the last 8 weeks talking about. We've also spent a lot of time filling out this logic model. To reorient us, this was introduced in week 2 as a key integrative theory model and framework. We talked about how in the usual status quo, we start knowing what the thing is, and we look at the thing's effect on patients. And over time, we've hopefully helped you to think about this more holistically. So in week 3, we had a great talk about barriers and facilitators or contextual determinants. We talked about what conditions make it harder or easier to implement or improve a thing. We then spoke in week 4 about specific actions we can take to implement that specific thing. And then in week 5, we talked about success for the health system. In week 6, we talked about the process that one could use to go through these steps. In week 7, we talked about how to make sure partners were central to this whole flow. And in week 8, we talked about this relation to QI. Now we're going to be talking about a kind of different logic model. And by the end of this talk, you'll see how a logic model might look with a dissemination lens. So the D. So if we think about the I as all about supply, the D is the public health demand gap. Or in other words, the gap between those who need services versus those who receive services. And this is also a slide we shared in week 1, but I just wanted to reorient us that we have a massive problem that when we think about the proportion of people who need services versus those who get it, there are major gaps. So this infographic has 3 illustrative gaps. For every 10 persons with a substance use disorder, 2 get care, only 2. For every 10 persons with a mental health disorder, only 5 get care. For every 10 persons with a physical disability, 7. We obviously want those numbers to be 10. And this doesn't even comment on whether that care is any good. So this is just people getting any care at all. We also talked in week 1 about how the level of unmet need tends to be the greatest among those with the least access to education, the greatest poverty, and those from racial and ethnic minoritized groups. So we have massive health disparities that we really need to be centering when we think about increasing demand. I was an economics major in a former life. So I like to note that when I say demand, I don't just mean people wanting services. I mean people being able to access services. So I think about demand as knowledge, awareness, and access. So all of those things we can think about as dissemination issues. To really kind of put this together, we have this tent of circles that was created by Enola Proctor, where we really can think about health services as a big umbrella in which our work is situated. Within that, there's health services research. And then dissemination and implementation are kind of complementary circles where dissemination research really does overlap with health communication research. A lot of you put that in the chat. We had words like communicate, spread, flow, while implementation research is adjacent. And it tends to be more in the implementation side that QI science tends to have the greatest overlap. But we're going to talk about a case example today that really kind of nicely is right at the middle of that Venn diagram of dissemination and implementation research. Just peeking at the chat if there's been any new questions. Okay. All right. So you had 3 readings about dissemination science. And the scoping review by Bauman and colleagues is a really nice place to start. It basically does a detailed review of what do people even mean when they're talking about dissemination research, and what's the language people are using, and what are the key terms. So one of the things they did was they actually took all of the definitions that existed in the literature. I don't expect you to be able to read this, it's too small, but you hopefully read it in advance of this class. The key takeaway is that the terms that are used in the literature really jive with what you were all putting in the chat. So they identified 12 distinct definitions of dissemination science and dissemination in their scoping review. And the key themes were the words diffusion, spread, knowledge, awareness, flow is one that didn't make it into my slide, and transferring research. So all the themes that you put in, that's really what dissemination research is about. It's thinking, how do we actually get people to know about these services with the hope that we can be driving greater utilization of these services in the community? Let's think about the logic model. So I just spent some time kind of reorienting us to an implementation science logic model. Let's think about this as a dissemination science logic model. So if we were to think about big buckets of determinants, dissemination strategies, and dissemination outcomes, The Bauman et al. Reading did a really nice job kind of pulling these together and summarizing what some of the key things might be in each of these buckets. So let's take a look at each bucket in turn. So in the Bauman reading, they had a table 4 where they summarized factors that might affect the spread of information and what they were calling dissemination determinants. They identified 17 unique factors, kind of food for thought for you all. I wasn't convinced they were really 17 unique factors. A lot of them seem like the same thing with different words, but you can all decide that and discuss that in your groups. But there were a lot of themes like the content of the message, the source of information, the characteristics of the thing itself that you're trying to disseminate, and then the characteristics of the audience, and really the segmentation of that audience being really key. Dissemination strategies are then the actions you would take to try and spread that information, increase knowledge, increase awareness. And they had a really nice table 5 that summarized some of the key actions that can be taken. And here they had 9 big buckets. Again, we could have a nice lively chat about whether these are distinct, and how they overlap with our implementation strategies. But there were some nice key themes here, some being to identify the gap in quality, to really think about determinants of dissemination, and then separately determinants of uptake, which I thought to be kind of an interesting way to slice that. There was themes of adaptation, themes of funding, policy change, monitoring and evaluation, sustaining knowledge, and increasing audience skill. And then they had a nice table of dissemination outcomes. And here there was a lot of overlap with our implementation outcomes. But there were some new constructs that I thought were valuable for us to note. The new ones tended to be about the use of knowledge, people's emotional reactions to messages, whether it affected someone's decision, whether it was persuasive, changes in policy, and then concepts of confirmation and accountability. All great food for thought about how we might measure these types of initiatives. Another reading was one that's near and dear to my heart because it was one that I wrote about 10 years ago, but I was really kind of thinking about dissemination science through a marketing framework and thinking about concepts of marketing that could help us to really be mindful of when we're trying to disseminate. So this was a figure from one of your readings, and this figure is about thinking about the concept of push versus pull marketing. So if we think about everything we've talked about the last 8 weeks through an implementation lens, I would argue that through a marketing sensibility, that's really thinking about people developing treatments and researchers trying to increase awareness of the people that are likely to deliver them, which in marketing language is an intermediary. And then that person goes out and offers it to the end user, the client, the patient, the customer or consumer through marketing terms. So that in that kind of framework, we're pushing demand through the chain. So the researchers kind of pushing it out to people in the community that will deliver it, who then push it out to patients. There is a complementary way of being, which is what's called pull marketing, where you can think about when you develop a treatment, going right to the end user, the patient, and thinking about trying to increase their knowledge and awareness in hopes that they will go out and seek that service and kind of pull demand through the chain. Classic example is direct-to-consumer marketing of pharmaceuticals, which notably the US is one of only 2 countries in the world that it's legal to do that. But it's been shown in multiple studies that actually does increase demand. It increases demand both of those that prescribe, and it increases demand from patients. So you can actually market things to the end user. And for many of you that do things like digital health, that probably actually makes a lot of sense to be thinking about marketing to the end user as opposed to an intermediary. So these are complementary ways of thinking about marketing. I also just like to always note when we think about dissemination science that we are not starting from scratch. There's such a wealth of research in the marketing literature that can help to guide us. So in that 2015 paper, I alluded to a framework, the marketing mix. It's there on the left side of your screen. And in other work from our team, which was not assigned to you all, but is something that can certainly be referenced, we had this visual of the marketing mix and how you could think about using these concepts from marketing to really make specific questions to guide your dissemination of a health service. So specific questions like, where does the customer want to receive this service? What types of places do they use to search for information? Which channels do they use? Who do they want to deliver the message? Those are all key marketing questions that you could use. So keeping that in mind, there's a lot of synergy there between the work that we read from Pirtle and colleagues. So Pirtle and colleagues had a really nice call for a data-driven research agenda for dissemination science. And what I really wanted to highlight was early in their paper, they had 4 bulleted questions that could be key questions you could think about as guiding this type of work. And I put those here, and I think they're a really nice reference point. And the questions are: what information should be included? Who should be delivering these materials? What should be emphasized? And how should the materials be tailored? And then a question they didn't ask, but that I think is the million-dollar question, so I wanted us to be mindful of it, is what strategies should we be using to disseminate these materials? If you were to try and think about synergy between this reading and the marketing mix reading, I would argue that these are questions related to product and promotion. So just food for thought. Pirtle also had a really nice table. I don't want to belabor this, but just to kind of get us thinking before we go into our small groups, that if you're trying to come up with a research program for data-driven dissemination, you can think about different types of studies as well. So you might do a formative study where you're just talking to people, understanding your audience's preferences for information. You might do research to segment your market or your audience, and be thinking about like who exactly you're tailoring what messages to. And then you can also do what we would call dissemination effectiveness research, where you actually test strategies to see which strategies are most effective. Before I turn it over to Nanette to dive into a case, I wanted to revisit this beautiful slide that Corey Bradley shared in week 1. This was such a nice anchor for us as we started the course to be thinking about centering healthcare equity within implementation science and reminding us that everything we do should be done with a lens of anti-racism. And so I wanted to challenge us as we think about dissemination science to try to do that through a dissemination lens as well. So Dr. Bradley had shared this really nice table in week 1 about implementation science constructs and some recommendations. And I took a shot at making some of those recommendations through a dissemination lens. So the same principles we talked about in week 1 would apply here, but through a slightly different lens and different set of semantics. But we would be focusing on equitable diffusion from the beginning. We would be thinking about selecting our interventions with high disparity populations in mind, and we would be thinking about the dissemination right up front. I always love to say in a former life, in addition to being an economics major, I worked in business and worked as a consultant. You work with a pharmaceutical company, the second there's a signal, the marketing team is right there, thinking about the dissemination strategy and thinking about what the audience is and how to get the message out. We need to do a much better job of that in academia. We need to recognize that one-size-fits-all dissemination strategies will leave many behind, and that we might have to work more slowly and more intentionally to disseminate to specific audiences that can most benefit from the services. We need to make sure equity is central to our outcomes, and we need to really be thinking about the science of adaptation, not just for our innovations, but I would argue for the messaging around our innovations as well. So now I have the pleasure of turning it over to Nanette, who's going to actually try to bring some of this to life with a dissemination and research practice in action example for us.
Thanks, Sarah. So I think I can bring it all together. A lot of the principles that you mentioned will be in this case example. Next.
Sorry, my slides are freezing.
Don't worry.
I'm doing my best.
I've been there. So just a little bit of background. The Implementation Science Coordination Initiative is funded through NIH and has been working for 5 years now to try to increase use of implementation science in HIV. It hadn't really been there before and didn't have much of a presence in the HIV field. So one of the things that we started doing is conducting a comprehensive literature review of both determinants for key HIV interventions and then implementation strategies for these interventions. And as we were doing this, there weren't many because, again, it's new in the field, but as we were doing this, not all implementation strategies were equal in terms of their potential effectiveness. Again, a lot related to the fact that this is still new in HIV and not many formal implementation research studies to date. So we thought, well, now that we have strategies and as we have more, we really need to think about which strategies we want to disseminate and promote. So we need to assess the level of evidence. And there are a lot of models out there to measure level of evidence of interventions. There's, of course, GRADE, and then in HIV, there's a HIV compendium, which disseminates evidence-based and evidence-informed best practices. But there really wasn't any formal criteria to evaluate implementation strategies. So we set out to try to figure this out and come up with criteria and levels of evidence for implementation strategies. Next. So we embarked on this process through a lengthy feedback mechanism, and it included formative interviews and literature review to see like what are our starting point criteria. Then we had 2 eDelphi rounds and then piloted this. And the first 3 steps of this process, we involved implementation science experts, HIV practitioners, HIV service providers, and people involved in quality improvement. Next. I wanted to highlight the results from this are they're out in preprint. Currently, we are responding to comments, and below you can see you have the link to the manuscript. And this work was led by Dr. Virginia McKay at WashU, and really did a phenomenal work. So this is all to her credit. Next. So the criteria domains, as I mentioned, we started with, typical criteria that are used for interventions, and there are a lot of similarities to that. Study design was one of those. And in study design, there are lots of different methodologies, but sometimes study designs don't lend themselves, formal study designs don't always lend themselves to be able to identify effective implementation strategies. So, but we did indeed want to have comparison group and, a comparison pre-post of the strategy. Implementation outcomes, of course, don't really need to say that. There needed to be clear, defined, and they needed to be implementation outcomes as opposed to effectiveness outcomes. There need to be rigor and limitations needed to be described in the studies. We measured based on strategy specification, as you all know, really key from your other courses. And really kind of new to this was this equity impact. We thought it was really important that implementation strategies, given disparities in HIV, really needed to be an important criteria for a level of evidence of strategies. Next. So we ended up with 4 categories: best evidence, promising evidence, needs more evidence, and non-recommended. And, we thought it was important to have promising and needs, both because they might be relevant and usable at a provider level, and also to kind of highlight and pinpoint, research gaps, and maybe some researchers might be interested in exploring these strategies further. Next. So now my example is kind of at that intersection that Sarah mentioned between implementation research and dissemination support. So the implementation research led to identifying the strategies, identifying best practice strategies, and dissemination research is what we were really interested. Okay, we now have these strategies. I don't know if you all know, but HIV has a really a high level goal of ending the HIV epidemic in 2030. So we really need to get busy. We need to get these interventions and implementation strategies in the street. So how do we best disseminate those strategies? In our case, the audience was very specific to providers to use these implementation strategies. So we were really focusing on the system, and that's more kind of the push strategy that Sarah mentioned. Next, maybe we can, next. So determinants, those have been really nicely studied. I'm borrowing here from a chapter by Ross Bronson in the Dissemination and Implementation Research in Health book. And these determinants resonated with this expert panel that we convened to ask them, how do we best disseminate these implementation strategies? And again, this expert panel was mostly composed now of representatives of the audience. So we had, commissioners of health, we had HIV service providers, we had national organizations whose job it is to disseminate HIV intervention. So really kind of experts in the street of what works and what doesn't. And these determinants resonated with them very much. And we kind of started with an overview as these determinants. They understood the best practice strategy. So what do we do? And we started brainstorming about dissemination strategies. And basically their recommendations were kind of fell in 4 buckets. Marketing and tailoring to the desired audience. And again, the audience here were service providers so that they could adapt these implementation strategies. And many of these align very nicely with the Bauman strategies that Sarah presented earlier. And a couple of things that came up was a trusted messenger. So it really needed to be somebody who is a peer, is, tried this out in a similar setting to them, they're well respected, and they're worthy of kind of taking note of what it is that they're proposing. A clear value proposition. So if people are really have a lack of time, they're worried about trustworthiness, there's information overload, there needs to be something that really captures their attention early on, really succinct, and that's a clear value proposition. Why is this needed above and beyond what I do? How will this make my implementation better so I can serve the people who are in need? And how much will it cost? So that value proposition needs to be really clear in whatever it is that we're disseminating. Principles of materials was another thing they identified, and this was really key because right now what exists in the HIV world are 100-page implementation manuals, which we really do think are not being used. So, but they're absolutely essential for somebody to know how to use these implementation strategies. So a couple of recommendations on how to do that were have a variety of products of different level of specification for the people that are going to be adopting it. So maybe, the program director is going to say, okay, the value proposition is good. I understand what this is. You all move forward. And then there are certain sections by role. So somebody doesn't have to read all 100 pages. They can just go to the section where they can see themselves and clearly understand what it is that they need to execute. Co-production with end users was key. So making sure that it's in the language that they understand, that the content is at a level that is germane to them and their expertise. So involve them at the beginning of dissemination. And then how to actually disseminate. So, capitalize on existing networks that support information sharing, education, and technical assistance. Next. And dissemination outcomes that were kind of in everybody's mind of what they wanted to achieve at the end of the day was increase awareness of implementation strategies. So right now people don't know what implementation strategies are, let alone which ones are best for them. Persuasion, some of these implementation strategies take time and take money. So why is it really worth having? So we wanted to be able to persuade people to use it. Informed decision, knowledge gain, and adoption. And just briefly, I can tell you that we then presented findings from the expert panel to a community advisory panel that we have, composed all of HIV service providers in prevention and care. And all of this really resonated to them. So it was validated by potential end users.
Thank you so much, Annette. I love that case because I love that it brings together the I and the D side. Thinking about disseminating implementation strategies is a really cool and novel approach. And I also really like the reminding us that, even the what of what we disseminate can be a co-designed and co-decision driven process with our partners. So also really ties back nicely to week 7 of the course. So really nice way for us to be ending. We do have some exciting announcements that we want to remind you of before we go to our group. The biggest announcement is that in lieu of a didactic session for our final session of the course, in prior years, we've always had people just come via Zoom, and we've said, bring any questions you might have. This year, we implore you to bring any questions you might have in person, and to join us for a light lunch and gathering to network, meet your group members in person if you're able to. So it will be at the usual time, but we have reserved space in the Ryan family atrium. These slides will be posted, but here's a little visual of where we'll be located, and right in this nice big space. And if you have young children in your life, there's a theme lately of some kids are doing book parties. So we are adapting the book party theme and doing a reading group party. So you are invited to our reading group party, and we hope that you'll join us for some networking in 2 weeks' time. We do also hope that you'll enjoy your final group session, and I hope you'll join me. I want to thank all of our guest lecturers this group session, and I really want to thank the small group discussion leaders who have done an amazing job and very generously donated their time to make these small group discussions work. And I want to thank each and every one of you who signed up for the course, and those of you that signed up to be peer discussants. This year, we had really record engagement of the peer discussants. When Dennis and I were flitting around, we'd see people bringing slides, bringing visuals. So we really thank you all for just elevating the caliber of the conversation. These questions will be broadcasted to your small groups, but just to preview, we have 3 big buckets of things we'd encourage you to think about and reflect on with your group. The first is to just think about dissemination approaches you might already be using, and how, if at all, the readings might inspire you to modify that approach, if it will. The second one's a more provocative question. There actually is some discussion in the implementation science field of dropping the D. I'm in a work group of dissemination scientists that folks were saying they didn't know if we really felt at home in implementation science, and that perhaps this really should be a field of health communications. And some who shall remain nameless even argued before we started that our center should not have the D in it, and that we should just be CIS and not CETIS. So would love to just get you to reflect on that, and whether you think dissemination science does have a place in an implementation science broader umbrella, and why or why not it might. And then finally, if you have time, you could also reflect on just measuring impact, because measuring impact of dissemination science tends to be a little bit more complicated than we might think. So without further ado, I think I'm just peeking at the chat, seeing if there was any questions. I'm seeing some great communication questions here. So perhaps if we broadcast these questions, we can also send some of Cindy's questions to the small groups as well. All right, thank you all so much for joining, and we hope to see some of you in person in 2 weeks.